time. So I'm going to sort of jump in, okay? And I'm going to sit, if people don't mind. So we have a big subject to handle in 20 minutes, so it's impossible, so I'm not going to really try to handle it in 20 minutes. But I don't know how controversial a statement this is. Does anyone here think that that healthcare is kind of working just as it should and dying is as easy as it could be? Okay, okay, great. That just saved me about 5 hours of work. All right. You know, I'm going to start with, well, David Bowie, in honor of David Bowie. You know, I just love his music, but more to our point here, here's a guy who did what I hope we as a society can learn to do, which is he confronted his death. He looked at it. He worked with it. And his final music, his final album, I don't know if you guys know, is all about his own death. And so it was his final creative act. I think we think of death and dying as this anti-creative thing. It's where everything's being taken from us, where it's all negative. So he gives us the first answer to the question of the problem of dying. He paid attention to it. He looked at it. He worked with it, which is really instructive for all of us. And working at Zen Hospice Project for the last 5 years as I did, this piece of paying attention really came to the fore for me. There's a real craft to paying attention to something, especially something as difficult as the abyss. But when we don't do that, all sorts of haphazard things happen, and we get these unnecessarily horrifying deaths. Or we're surprised someday to learn that we're dying. So that's problem number one. Okay, we're not going to do, these are just sort of the pillars. What I imagine so we agree there's a problem. I think these are the 4 pillars that we need to address to change things. So society, right, we all need to wake up. We need to participate in this. We cannot just hand ourselves over to the doctors and think everything's going to be fine. No way. I'm a doctor. I can tell you that with confidence. And again, that's not easy. Again, that is not easy. In workforce, similarly, we need to be better trained. Atul Gawande's book, Being Mortal, points this out. Doctors, clinicians generally are pretty good people. It's not that they're trying to be nefarious or point us in the wrong direction. It's for the most part, doctors and nurses and others aren't very well trained in having difficult conversations, aren't very well trained beyond the point in which there's nothing to fix. So when there's nothing more to fix, we say, oh, I'm sorry, there's nothing more we can do. But of course, if you expand your purview to conclude support and non-abandonment and kindness, well, there's always something we can do, right? Okay, so those are the first 2 bullets. Policy, we're not going to touch that one, but that's a big piece of this puzzle. Infrastructure is another. So another way of looking at the problem of dying is people aren't getting the deaths that they want and could have. So I draw a big distinction between the suffering that comes to us by virtue of Mother Nature. You know, my favorite analogy is, think about if you lost your home to a tornado. You'd be sad, right? But it's a very different enterprise than losing your home to arson. It conjures different emotions. Okay, so I think the fact that we die is not so stunning, but the fact that we die when better deaths and relief and peace are actually accessible, are actually possible, but we just can't get to them, that's an infrastructure issue and a policy issue. So just calling out the pillars of change here. Okay, now again, the rest of the talk is largely about getting us into the room together. Okay, we're saying we want to pay attention to the subject. How do we do this? So these are some prompts to help us get in the arena together. So one is to point out painfully obvious things, which are dying people are still living. I think you actually have to say that. And it also conjures up, there's some good news in that, by the way, because the way we live will help inform the way we die. It's not some exotic, esoteric phase of life that that's not knowable. Death may be unknowable, and maybe some of you would argue that point, but to me, I think death is unknowable and is the absence of life. Dying, however, is absolutely entwined with life, and it is much more knowable. And when I talk to people, whether it's at Zen Hospice Project or in clinic at UCSF, you know, when it comes down to it, most people I've talked to are really worried about the suffering they imagine dying to entail. I have not met too many people, I can count on one hand from clinic days, of people who were afraid to be dead. There was a fear of the abyss. But for the most part, I think we're afraid of the suffering that dying implies. Okay, so I just want to call out, most of you guys probably know what palliative care is, but it's always worth reminding ourselves. Even for all palliative care clinicians in the room, I would still be putting this slide up. This is a quietly revolutionary field, at least in its promise, in its potential. This is what this is what how CMS defines palliative care. Can you see that well enough so I can just shut up and let you read it? Yeah, okay. Okay, so contrast that with the rest of healthcare, right? Cardiology, nephrology, named for organs. Oncology, hematology, named for disease. This is named for the human condition, right? Everyone suffers, right? Everyone. Does anyone want to argue that point? No one ever has, by the way. Actually, one person in Utah said that they hadn't suffered, but I talked to him about it after. He said, I've had such a privileged life, I just feel so ashamed that I have to say I haven't suffered. I was like, oh, okay, well, anyway, he's an outlier. We take him off the table. No one has ever said they don't suffer. But suffering, so we've all done it. It's a human condition. It seems part and parcel of being a human being. Traditions like Zen will help point this out. That's the starting point, is that we suffer. So it's not this anomalous surprise, right? And so we've all done it, total inclusion, and working this field is very different, right? How many brain surgeons have ever had brain surgery on themselves? Well, all palliative care clinicians suffer. There's a totally different buy-in and a relationship between caregiver and care receiver in the field, which I love. Okay, and the other thing about this to point out is, while the rest of medicine, reasonably so, is always in the pursuit of objectivity, palliative care embraces subjectivity. You know, I can't test you for suffering. You have to tell me that. And one of the great potentials of this field is to upend the power dynamic, which is really thrilling. The patients are in the driver's seat. They tell me if they're suffering. I don't tell them that, okay? That's thrilling. The second half of the definition, I'll be quiet for a second. So they call out some of the domains of suffering. No one discipline has a lock on suffering, right? But this is right after the 2009 death panel debacle that somehow upended all of this and made it about the lack of choice. No one in the field saw this coming, by the way. So it's interesting that it lands as it does. You'll notice too, in this definition, there's no mention of time. There's no mention of death or dying. And so this is, again, something you guys probably all know, which is that hospice end-of-life care is a piece of the puzzle of palliative care, but it's also an insurance designation. It's the 6 months or less to live. It's the, well, you can go for hospice, but you can't go for acute care. It's that's an invention. There's nothing natural about that. You don't change color at 6 months or less to go. But to the point, so to get around some of the inborn restrictions of the insurance designation, we have this field of palliative care, which is much larger. And as you notice, the definition does not include a mention of time. Suffering, okay, we're whizzing through these guys, but I'll just point out here, well, first of all, suffering is very difficult to define. I like to think of it as a wedge between the reality we have and the reality we want. All right, so you have two responses to that definition. You can, in the sort of Zen tradition, get really practice at accepting the reality you have and not trying to change it all the time. Option one, very hard to do. Option two, change the world. Change your reality. Also very tricky. So I think most of us try to do a little bit of both. But the other thing I want to point out here is what I snuck onto the slide, which is the bottom right. You see logistical suffering. This is the sad part. And I, as a clinician, I'm close to burnout much of the time, not because I'm meeting difficult diseases or tough family dynamics. I'm burning out because I'm working in a system that's not designed very well. So I just want to call out that the health system itself can be a source of suffering, which is a real shame because, as we probably all believe, people go into healthcare for generally really good reasons. And it's demoralizing to work on behalf of a system that doesn't serve well. Okay. So on that note, a design brief perhaps, and this is the tips of icebergs here, guys, but perhaps the construct of the healthcare system is off. For the last 150 years, I think we've focused on disease, the idea being if we can stamp out disease, we've stamped out suffering and we'll live forever. That's kind of the assumption. Who would have guessed in the early 20th century that brainless little bacteria were going to get smarter than our drugs, right? Who the hell would have guessed that? Who would have guessed that if we cure infant mortality, behind that is waiting all sorts of other ways to die? Or if we push back on heart disease, then we're going to unearth new cancers. There's an insistence here about that dying just seems to just not be willing to leave the room. And I think that's kind of where we are now. We're at a crossroads. This is a reckoning for the healthcare system. And for my money, this has a lot to do with it. Those of us who have been through hospitals as patients, you can feel yourself being processed. You are incidental to your disease. And there are some good reasons for that, but it's also there's a ton of fallout from that. And again, it's one of the ways in which we suffer. We've tried to separate medical from social issues in the healthcare system and what we pay for. In a person, I mean, if you go to the ER of San Francisco General, or any county hospital, it's filled with people who are there for social issues, but they're ending up in the medical system nonetheless. So that's a false dichotomy, and we have to sort of upend that one. There's a lot more to say about this, no time, so we'll keep moving. Okay, here's a good reminder to us. Again, working around in a Buddhist tradition, it's been very interesting. I mean, I will meet some folks, volunteers at Zen Hospice, and others who will point out to me, well, will say things like, no birth, no death. And I find that interesting, but I can't soothe a patient who's dying in a few weeks. Say, oh, don't worry, there is no death. It doesn't really help. And so I'm meeting people, you can't even, so what is death? When do we die? We can keep a body alive forever on machines. Is that alive? I don't know. Actually, we're at a point where we actually have to redefine or think through the definition of death. So one thing I think that we can agree on is that this body dies. Okay, and death comes to this body. And by the way, I hope we're getting over this separation between mind and body. Okay, so that's just meant to ground us and also meant to honor and reward what it is that this body does before it fades away. This body feels things. When you think about the joys in your life, and if you really are serious about living until death, well, what gives you joy in your life? Well, a lot of it just has to do with movement or in time and space. And using the senses that we are given to enjoy our food or music or whatever it may be. It's really this slide, I mean it as a nod to the aesthetic domain. And then we uptick that as part of the therapeutic response. That's not sort of aromatherapy that's cute on the side if we can, we'll let people come in with their aromas. No, it needs to be much more integrated, all right? Food for thought there. Okay, this one I love. Sorry to tell you guys, but we are the dying. You are one day very likely going to die. I hope that's not shocking, but I think it's very useful to keep that in mind. For one, that means there's a total inclusion implied in that. All of a sudden, with this major theme of life, we have something in common with people all the way halfway across the globe. I have something in common with people who live in the jungle. I have, it's a major thing for us to share. And not just the fact that we die, but that we humans have the forethought to consider our own death before it happens. So it's a major thing, and therefore it has this potential to be a force for justice, sort of ashes to ashes. We can have wildly different experiences in a life. I've seen at Zen Hospice and at UCSF where people had just the worst luck in all stretches of their life. And they're able to eke out some community and peace in the final hours and days. And it's like, with a happier ending, it's like that whole life all of a sudden felt worth it to the person. Something that ends well, it's like even the struggles to get there, those kind of fade quickly. So there's this potential for justice in this and absolute inclusion, which I love. And also a nod for language. We've got to be careful when we say the dying. It's like the homeless. It's anytime there's the before preceding the next word, note, you are actively separating yourself from that thing, okay? So we are the dying. And the good news here for designers and clinicians is also that, well, when you think about what dying people need, well, think about what you need. The empathy becomes sort of the way forward. All right, healing versus curing, big difference. Curing, fixing is great stuff when it can happen, but it can't always happen. Healing, however, can, I believe. All right? So healing seems to be much more of an internal process. I, as a clinician, I may be able to externally come in and help cure or fix something, but I cannot force someone to heal. That is an internal process. I can be an agent on behalf of that, but that's an important distinction and an important goal for healthcare. If we just stopped at curing, we have a lot of problems and we're just kicking the can to some other system, some other industry, someone else to take care of. I think that's a mistake for a number of reasons. So perhaps healing is a better goal. Things change. And one thing just to note as we're designing things, thinking through how things can be better, is to note how people's minds change, by the way. The closer, we know this from data, the closer people get to their own death, their minds change pretty rapidly of what's important to them, what they want. Do they want CPR or do they not want CPR? So you have to, I think maybe the name of the game now is, for the system, is nimbleness, dexterity, agility, that we can bob and weave with people. Okay, I don't think that anything, I don't know that anything else I'm saying today is an opinion, but this is an opinion, just to note it. I think, and a lot of people have told me, patients who are closer to death than me, have told me that this is true. There are things that are worse in life than death. I've offered up as food for thought, and especially now since June that we in this state have assisted dying legislation, it's a worthy question for all of us to ponder. Choice. Okay, I watch my fellow clinicians do this all the time. I think we equate choice with freedom, and freedom is a good thing, and freedom is if any felt freedom is pushing back on death in some way. Yeah, well, I've watched myself and other clinicians who are just so eager to offer some choice to people, offer up false choices. That's like a new form of negligence. That when we offer choices that we know in our heart are not going to help people just to offer something, that's a negligence, I think. We have invented a new kind of suffering in those moments. So I think we have to be very honest and very careful with each other on this one. And by the way, if you're in the bed and if you're exhausted and death is coming, sometimes being offered choice is not very helpful, even if they're real choices. Right? Choice takes energy to make, and then it means you can make the wrong choice. Sometimes it's just tell me what to do, you know? All right. This is another way. We suffer because of our language. We suffer for our constructs. And in medicine, where we have normal and we have pathological. Now, that's very helpful on a slide histologically to point a cancerous cell out from a healthy cell. Okay, but that's a convention. And we get into trouble and we confuse our conventions with the reality they're meant to help us digest. Okay? To be clear, who here has never been sick? All right? That's just not part of a normal life, right? Aging, suffering, these are all, this is normal. So we send these aberrant signals to our patients, especially with things that aren't fixable, that somehow they're pathological. And I, as a disabled person, have a lot of stories around that. The disability isn't so hard, it's the way that society treats you is so dang difficult. Okay? So this is a very, sort of depathologizing things, I think, is a very important thread for a way forward. Okay, here is my favorite slide. This is not a mistake. This is simply to point out that it's really, mystery is a very beautiful thing. Not knowing is a very beautiful thing. You know, this is another great way, you know, if you're ever interested, come volunteer with us at Zen Hospice Project. And we also have education programs which are very interesting that will help you kind of grasp not knowing and the profound sort of beauty and potential that offers up. This is also a nod to, in health sciences, we tend to call, you know, mystery ignorance and crowd it out and say, well, no, we got to work harder. Everything's going to be knowable if I just study a little bit harder. Maybe, okay, someday. And I also think there's a lot of room and beauty in not knowing, in mystery. And I think some of the most therapeutic moments I've had with patients have been when I said, you know, I don't know, but I'm not going to run away. I don't have an answer, but I'm going to sit with you. That can be an incredibly profound moment. Okay? So make room for mystery. Quality of life, not much to say about that, but other than to say that now, first of all, subjective, you guys tell me what quality of life is. And secondly, quality of life and quality of health. Two different things, but I think we're learning that they're actually entwined. We know from more and more data that living well and living long are related, not opposed. And I know a lot of lost souls who have perfect lipid panels and perfect blood pressure. So I think maybe our goal is quality of life, not just quality of health, or maybe those definitions need to entwine. Okay, we're running out of time, guys. Less horrible, more wonderful. Most people end up in the healthcare system because something's gone wrong, right? There's a problem. We've crowded out preventive care and primary care. For the most part, people end up in the system because there's a problem. And our goal of mitigating suffering is a noble one. And if we can do that, that's great. But I would just challenge all of us to raise the bar a little higher I mean, let's make life less crappy, but also can we keep an eye out for well-being, for wholeness, for healing, for something being even more wonderful, okay? Here, we're out of time. I will just simply say, this is from data from the California Healthcare Foundation, interviewing a couple thousand Californians about what's important to them at the end of life. Two things. Notice how few of these have anything to do with medicine or healthcare. Okay? Healthcare is sort of de facto default place where dying people end up, but we're not necessarily much more qualified than an average citizen to deal with it. The second point is this burden thing, being a burden. This is an indictment, I think, of society, that once we've lost our primary purpose, like there's no space for us on this planet, we just sort of have to get out of the way. We've got to get way better at repurposing ourselves and encouraging each other. I mean, think of all the wisdom languishing in nursing homes. What a shame. And then the last point here, and then I really will stop, is that burden, purpose, meaning, good stuff. I love purpose, I love meaning, but I also love meaninglessness. And I would challenge us all to make space for things that have no purpose whatsoever. Playing with my dog, riding my bike, sun on my skin. These are reasons for living, but I'm not sure they have much of a purpose. Okay, that's it. Thank you very much.